Welcome back. Our final section is on implementation challenges. And as we have heard throughout the day, that is really the trick to make that happen. Because no matter where you are in the innovation chain or what kind of actor you are in the ecosystem surrounding healthcare services, you can never escape the final test of every new innovation and service, getting it out to the end users and the beneficiaries. And I know from experience that implementing designs into the world is hard work and requires a lot of grit. It is therefore my great pleasure to introduce our next speaker, who will be joining us via Zoom from London. It's Professor Julie Reed. She's a guest professor at Halmstad University and former Deputy Director for the National Institute of Health Research Collaboration for Leadership in Applied Health Research at CARE, Northwest London. So I hope Julie is with us online.
Hi.
Hello, please.
Okay, thank you very much for the invite. And yeah, I was delighted that Marcus has set me up to address this, the most difficult last two steps of implementation and improvement. And I've also been really encouraged today to hear the focus on collaboration and the importance of bringing together people from different expertise to help solve this problem. But my experience as a collaborator is that this can often be quite challenging, particularly with expertise in implementation and improvement. You're often approaching your colleagues and saying, that idea that you're really excited about, it may not be that simple in practice. And that can be a challenging role in any collaboration. But as I put in my profile, I see myself as a critical optimist. I think there are real challenges, real difficulties that we face in implementing new innovations and evidence into practice. But I strongly believe it's only by doing this that we can actually achieve the goals that we want. We can't diminish or trivialize these challenges. We need to embrace them and be curious about them if we're going to succeed. And thankfully, we're now in a position where we have over 20 years worth of advancements in implementation and improvement science that really provide us clues as to what to expect on these journeys. So we really have no excuse anymore for failing to expect the unexpected. But to start off my talk, I'm hoping we can make this a bit interactive. And I wanted to ask you to engage in this Mentimeter exercise so you can share your perspective on your role. So you can start logging into the Mentimeter. I know you've been using it through the day. And the question I would like you to consider is where, in your role, where do you spend the most of your time or your effort? So as you're starting to look at the Mentimeter, and you may have a very strong opinion already, but I'll quickly talk through this cycle for improvement. So first of all, step one of the cycle for improvement is understanding where we really are, what actually happens in practice. So you may spend most of your time here if your role is a clinician or on the front line or a patient with lived experiences of the services, or perhaps you're a qualitative researcher or quantitative researcher really getting to grips with what's happening on a day-to-day basis in the front line of care. Stage two of the cycle for improvement is identifying needs and opportunities. So you may well be here if your job is a strategic, setting strategic direction or commissioning services or commissioning research and thinking, what are our needs and where should we be focusing our effort? And that really links to stage three of the cycle for improvement. Whose job is it to identify the priorities? And this is so important. We have finite resources, so we can't address every challenge with equal effort. So where are we going to focus our efforts? So perhaps your job is there. Number four, develop and identify potential solutions. So any of you who are involved in developing new innovations, new tech, evidence, you could actually be in the process of developing these new interventions. Or maybe your job is reviewing evidence. So you could be synthesizing large amounts of evidence for guidelines, for example. And finally, the all-important step, implementation. The people who are actually working to put these new ideas into routine practice. And obviously the whole purpose of the cycle for improvement is to change what's actually happening in practice. So have we really changed patient, staff experience and outcomes? So I can see the results. I'm just looking to my left because I have a separate laptop with the results coming on. So I can see some people are starting to come in with some votes. So please cast your votes. And it's really helpful just to see the distribution of the activities that you're involved in. Okay, so far we have the most is in understanding what actually happens in practice. So I wonder if we have lots of clinicians and healthcare practitioners in the room. And we just have one person involved in implementing solutions. Oh, we have a few more people here identifying priorities. Okay, so with that, I'll let those answers start racking up, and yeah, we can look back at that in a moment. But I just wanted to reflect in our experience. We find that often there's a real gap between identifying solutions and implementing them in practice. And this is what's often known as the translational gap. So most of my research is focused on the gap between evidence and practice. And so developing all these great ideas, but they don't always seem to be implemented into practice. And even if they are implemented, they often don't achieve the results that we want. And so there's this big gap, as people have talked about all day, between the great ideas and innovations and the potential we have and how that potential is being realized in practice. And from our experience, we really think this is because often we work in quite controlled or remote settings when we're conducting research or developing policy or new innovation ideas. Whereas the real world that we're implementing these ideas into is kind of uncontrolled and messy, these complex social systems that we're working with. And we believe that it's a failure to consider the real complex social systems we're working in at the point of developing new interventions and solutions that leads to this translational gap. So in my talk today, I want to focus on I guess, the service view. So I think a lot of the talks you've heard so far from the innovative view, and we have this idea of a pipeline of, we have these great new tech ideas and these great innovations. And I totally hear the work and the effort, the technical expertise, the importance of collaboration throughout this pipeline. But often you're quite focused on developing the innovation with the idea at the end that you have a product that you can share with people in practice. However, often when we're thinking of this innovation pipeline, we're imagining people kind of really excited in service and waiting to receive this new innovation, this new technology to change care. But the reality is, in service, people are often really busy just running to keep going, providing usual services, thinking about how they're addressing the constant problems and changes and constraints, of which the recent pandemic is a perfect example of how the system has just had to adapt to such a huge change, to change all of its services. And so all of the time there are these events and incidents which are causing people to just keep adapting to maintain the service provision that they want to give. And on top of all of that, they're constantly incorporating new innovations in usual practice. And that means that any one innovation that's coming through the innovation pipeline is going to be competing with many other innovations and change initiatives and ideas that a practitioner has to deal with in the real world. So my expertise is very much from the service perspective and understanding what it's like to be a recipient of these new innovations, whether it's new tech, new evidence, new policy initiative. And today I'm going to invite you to put yourselves in the shoes of people who receive your great innovations in practice, and to really emphasize that both of these worldviews are so important if we want to have a real impact on patient care and patient outcomes. So the case study that I would like to focus on to bring this to life focuses on improving patient discharge from hospital to community. And I'm sure you're all aware that timely and safe discharge is really important in terms of allowing a constant flow of patients in the hospital. We need to keep the capacity for new admissions. And also from a patient perspective, it's often much better to be at home with your family and your loved ones if you no longer need to be in hospital and you're medically fit to go home. So this is the case study I'd like us to focus on. I normally run this session as an hour-long facilitated session, so I'm just going to provide a few highlights from the case study, but at the end of the session, I'll provide a reference. If you want to go and do the full online session, we actually have an e-learning module that you can go and do in your own time. And just before I start, I will say that this case study is based on extensive international research. All of the events and quotes are real, but the intervention and scenario are hypothetical to protect the anonymities of the sites that I conducted the research in. So let's talk about the change idea. So in the aim they have is to improve patient discharge from hospital. And the change idea they have is to develop a data-driven discharge checklist. And your chief executive hears about this initiative from another organization that have successfully trialed this intervention. And the sales pitch is that this will help put data in the hands of the clinical decision makers to expedite timely, effective, and safe discharge from hospital to the community. So your chief executive is really excited about this change idea. They know that this is a real problem that you have in your hospital, so they're keen to find a solution. And they're also excited to know that this is compatible with your existing electronic patient record system. And they're aware that it's been successfully implemented. So for the next few minutes, I would like to imagine that you are in the shoes of the people on the front line who are charged with implementing this checklist into routine practice in order to improve patient discharge. And I'm going to ask you to make a leap of faith for the purpose of this exercise to assume that all of the IT issues have been resolved. I know that many of you focus on the technical issues, and these are real issues that we need to grapple with. But I want you to give you permission to think, even if all of the technical challenges are removed, what other challenges might you face in having a successful intervention? So whilst you're starting to imagine being this on the front line, and I want you to imagine that you're responsible for introducing this and what your next steps would be. So again, if you want to put your answers in the Mentimeter form, I'll be having a look as once I've read through the details of the discharge checklist to hear what your thoughts are. So this data-driven checklist, what does it consist of? Well, the intention is that it will automatically draw on electronic patient records to collate all of the outstanding care actions, so helping provide a really clear plan of what needs to happen before the patient is fit for discharge. To provide an estimated date of discharge, and the idea is this will both be for individual patients, but that also that can be modeled to predict ward and hospital occupancy. And to coordinate the follow-on care. So making sure the patient's ready to go with the ongoing support, including medications for discharge, patient information provision, GP follow-up appointments, and transport arrangement. And the intention is this would be used in all of the acute care wards. And the really important thing I will say before I kind of look and see what answers that you're putting in terms of what your next step would be, is that the intention is this is to be done by a multidisciplinary team and to facilitate discussion between the team. So when your chief executive learned about this from another site, they were really clear, this is just a facilitation tool to collect the data that empowers the multidisciplinary team to have the conversation, to take the actions and make decisions they need to support patient care. So it's really important that this isn't just seen as an electronic solution, but it's supporting better interactions and better discussions between our staff. So I'm going to just flick over to my Mentimeter and see what suggestions are coming up. Okay, so the first suggestion is that observations on the floor, it should be implemented in interviews with the staff. Okay, so actually understanding, well, what's going on in the current practices, how will this fit in, and perhaps understanding what the staff will think about it. And yeah, another great suggestion, understand the current state and map the process as it exists today. So these are really great suggestions. Often when I run this session, there can be, particularly with frontline staff, there can be a lot of skepticism. So like, oh, do we really want to do this? Do we even have this problem in our hospital? Is this solution going to work? And particularly, how will it duplicate existing care? So maybe we're doing some of this already and the chief executive just doesn't know about it. So really understanding how does this fit with what's going on already? And how the staff feel about it in relation to their existing practices of work. And then someone else is saying, check the steps in the current process. So this is a great idea too. One of the feedback we often get from frontline staff is, if we're doing a checklist, the idea is we should be getting 100%, we should be doing really well. But we know we have such a big problem with GP follow-up appointments that we're never going to get 100%. So that will be really demoralizing for staff. So why don't we go in and sort out our GP follow-up arrangements before we implement the checklist? And so that can be, really understanding this is a lot of detailed work going on behind the scenes. And then finally, someone's saying to have a test period. Actually, let's get out and test it. So at this point, I just want to reflect that there's actually no one right way to approach an implementation project. There are often many different issues that you want to understand through. Do you have the problem? What's the existing practices? What do staff think about it? Let's go and do some tests. So there are lots of different ways that you can approach the problem. But some are more wrong than others. Sometimes people suggest, well, maybe we should do an audit for 6 months to see if we really have this problem. And it's like, well, actually, can you really wait 6 months before you implement a solution? Do you have the time to spare? And also, people can often talk about engaging everyone in the hospital to make sure that they're happy, that there's consensus. And I kind of really get that in terms of, wouldn't it be great if we could sit down and discuss with everyone and make sure there's full buy-in? But often it's not possible to do this with all staff. They wouldn't have the time. And also, you need to remember, it's not just one intervention at once. There's often hundreds of new ideas and innovations coming into a hospital every week. So it just wouldn't be practical to engage everyone all at once. But okay, so thank you so much for your suggestions. I'm going to move on to what this team chose to do and how they chose to approach this journey. And I'll warn you, their approach wasn't necessarily perfect, but I think it's very typical of how people approach implementation projects. So this was the first attempt that they had at testing whether the checklist was going to work for them and adapting it to their local setting. So they decided to do a series of plan, do, study, act cycles. So this is a well-known quality improvement methodology. I'm not going to go into a lot of detail, but the idea is that it allows you to rapidly test and get feedback about how things are working and what problems you might encounter. And the philosophy behind it is to fail fast. So start on as small scale as you can and learn the mistakes on a safe and small scale as quickly as possible to rectify them. So I'm not going to go through this in a lot of detail, but just as you can see, they ran through there's 12 different PDSA cycles here, and each time they were scaling up their learning. So they first of all tried in simulation, so with no patients involved, just going out and speaking to staff and getting their feedback, incorporating issues with the checklist and making sure it fit with their local practices. And then they started actually using it with patients and trying it on quite diverse patients to make sure it would work for their patient population. And finally, they brought together multidisciplinary teams to do a whole ward round together. And they did this twice, one with the team that had been quite involved in developing the checklist and one with a new team. And at the end of this, they were really happy with the checklist. They'd made lots of modifications to adapt to their local practices and the language that the local care staff used. And they felt that it was really facilitating high quality conversations in the teams, and people thought this was going to be great. It was going to make such a difference across the hospital to improve patient discharge. So at this point, the chief executive decided, yeah, I'm happy with the work you've done so far. Let's launch this across the hospital. So the plan was for senior ward leaders to champion the use of the discharge checklist to staff to increase the initiation and completion rates of the discharge checklist. And what I'd like you to do is to think about what happened next. So go on to Mentimeter and enter your ideas. You can probably tell, as this is one of the a question I'm asking, that it didn't go quite as straightforward as they were planning, and they did encounter some issues. So I'm just going to go over to Menti and see if there are any suggestions coming in. Okay, so someone's saying that they need to build new ways of working by engaging all the staff and implementing it and letting patients know about the change of practice. So I guess that's a good question. What have patients been told? Oh, I love this first one that came, the next one that came in is nothing changed. So there's no difference. That is a good prediction. Okay, well, as you maybe are thinking, it's what your answers are. Oh, so here's another one coming in. It didn't fit with current practice. Well, I think that's a nice segue for me to reveal what actually happened. And as I do this, just to say, this is so typical across all of the teams that I have observed in my research, that we've actually given this a special name. And what we call it is the exploding PDSA cycle. And this is the name that we gave to a single test of change, or plan, do, study, act cycle, which results in a large amount of learning, identifying barriers and areas for further improvement. And so just as I was saying, I can see a number more slides have come up. So lots of people are quite skeptical, thinking that nothing has changed, nobody wants to change. There was no budget, so the implementation, it never happened. Oh, and perfect. They probably found new problems in other departments. So that really, captures a lot of what happened next. So let me talk you through the PDSA. So what they found was that, the senior ward leaders championed it. During the daily briefings and at shift handovers for 1 week. And what they found was that initially the discharge checklist completed really well. So it was up to 65%. But even by the second week, it dropped down just to 35% completion rates. And they said there were procedural issues with scheduling the multidisciplinary team ward rounds. So they weren't taking place. They found that the consultants started the ward rounds without other nursing or junior staff support. And as a result, the nurses were completing the forms on their own and not as part of an MDT in order to meet the external performance target. And overall, they found that everyone was frustrated by the amount of paperwork that they had to complete for each patient. So absolutely, as you predicted, there are so many issues that hadn't been thought through about how this intervention was going to work in practice. And I just want to highlight right now, there's a huge risk that people will give up and abandon on the intervention and just be like, well, we tried it, it didn't work, so let's look for another solution. This is too difficult. But this team, in all fairness to them, didn't do that, and they persisted. And so I don't have time to go through the whole journey, but I want to highlight some of the key learning points which may be applicable for any project that you're working in. So first of all, this was a team discussion I observed. The nurse says, well, we know we have to fill the discharge checklist in, but we don't really have time to fill it in as a multidisciplinary team round. So we always fill them in at the end of the shift for everyone at once. That way we know all the data is reported. Charge nurse, oh. Consultant, oh. The charge nurse says, well, but that data is for our reporting requirements. And the nurse says, oh yes, we always achieve our reporting targets. And so for me, this observation, which is not unique at all, we saw it across many teams, is that often people, you don't really know how the data is being collected. It's being collected by busy people in busy roles. And so that raises a real question, both for the data that's driving our AI work, but also for data on how well your interventions are being used, about how reliable is your data and how will you ensure it's having the desired impact. And so one term that you may have heard a lot that's given to this kind of behavior is you're hitting the target, but you're missing the point. So you're filling in all the paperwork, but you're actually not really doing any of the actions that are required to improve patient care. And in the sociological term for that is ceremonial compliance, which I quite like. In this next one, you have the consultant saying, I think the frustration is all around that they've got double the paperwork to what they had 3 years ago by all of these initiatives. And in many ways that just doesn't sit right. The nursing staff are already on their knees, stretched to the limit, being told to do this, that, and the other with no extra resource. So if you want people to do extra things, you have to give them the resource to do that, be it time, money, or otherwise, but you can't just expect people to absorb it into an already overloaded work plan. And for me, this is absolutely one of the foundational points of where implementation meets wider service improvement, is understanding how your intervention will fit with the other requirements and other improvement initiatives going on. So often we imagine our interventions being used in isolation and they work wonderfully, but when you pile 20 different things on at once, there's no way that a nurse has the time to fill in all the checklists with the equal diligence that they did when you were just studying that checklist in isolation. And the key point that we very rarely talk about is what constraints are you working with? And that's often time, staffing resource, and what can you stop doing if you're going to introduce something new? The next quote I want to read is from a nurse. So it was chaos. And, you know, the nurses at the end of the day, they were going into the notes. Oh my goodness, the doctor's been in and I didn't know he's been in. And we would be standing at the 9 o'clock board round, scratching our heads, you know, the team thinking, when will this person be discharged? What are we planning for? Meanwhile, the senior decision makers are out on the ward on their own. So it was just the system was broken. So for me, this is a really key point around how any intervention is dependent on other practices and processes that are going on in the hospital. And you cannot assume that these are being done well. So here, the intervention assumed that all these multidisciplinary team ward rounds were taking place and that the discharge would neatly feed this information into all these people waiting to, you know, discuss the discharge. But that's not happening. And so there was a flawed assumption about how normal practice was, and a huge amount of effort had to be addressed in the multidisciplinary team ward rounds taking place in order for the intervention to be able to work effectively. And why was it so hard to implement the checklist? Well, this is what the improvement manager reports about the behaviours. Some people have said that they never have a nurse with them on a ward round. And then you ask the nurses and they say that's because the person never comes when they say they're going to. And quite a few of the consultants are still in the mold of, well, you know, I'll say when I'm coming and they just have to fit in. So it's quite challenging. And what this project team realized was that, you know, the reason behind a lot of the challenge they faces were poor relationships, that there were these long-term feuds between nursing and doctor staff in some of the wards. That were completely preventing them to work together to find solutions to the problems that mattered, and were preventing the intervention from being used and deployed as intended, and clearly were having major impacts on patient care and the quality of patient care outside of the intervention, but just in terms of routine care delivery. So I think key questions to reflect on is, how is your intervention influenced by the quality of relationships? And what assumptions are you making about the existing relationships that are in place? So I don't have time to talk through the entire case study. As I said, the link will be at the end if you'd like to do it in more detail. But I can say over time, this team did, I think in the introduction, you mentioned persistence, and they really did persist and resolve all of these challenges. And it took over 18 months to kind of peel away all of these layers. But at the end, they had addressed the relationship issues, they'd embedded the multidisciplinary ward rounds, which was having benefits for patients far beyond the intervention itself. And the discharge checklist was being effectively used, and they'd noticed a big improvement in their discharge delays. And they also uncovered other issues, so radiology, pathology. It allowed, once they'd kind of stabilized the normal behavior in the system, they could start to see where other key problem areas were and starting to tackle them. So when I run this session at the end, I always ask the provocation, so would you recommend the checklist to other organizations? Or was it the checklist that caused the improvement? And I ask because if you were to evaluate this, you would see that there was improvement from when they implemented the discharge checklist. Over time, they achieved the improvement. But was it the checklist that actually caused the change? And so one diagram I show is often the program theory. So this was their program theory at the beginning of the initiative. So you can see they had a single intervention that they were hoping would influence all of these things and improve their aim. But in reality, over the course of the intervention, they had to do many different interventions in order to achieve the impact that they want and address many different areas. So was it the intervention? Often people say it was nothing to do with the intervention at all, and it was all the other work that they had to do in order to achieve the improvement. And you could take the intervention away and they would have still achieved the goal. But I think my provocation back is that actually I think the discharge checklist acted as a catalyst, and it really caused people to focus on what the problems were. It made clear all of these systemic problems that existed in the system, and encouraged people to pay attention and to resolve them. So finally, I'm just going to, we asked the teams how much effort they invested in each of these domains. So the adapting and developing the intervention, using the intervention, addressing the dependent process issues such as the multidisciplinary team ward rounds, and then addressing the dependent social cultural issues. And you can see from this slide that by far the most effort was invested into the dependent social cultural issues. And we've replicated this across a number of teams. And so far, this seems to be a very consistent trend. So I just want to finish really, I started off with this idea of the innovation pipeline and how this hits service and service practice. And over the 10 years of running the Clark program, we really evolved our thinking from this kind of linear pipeline to much more of an iterative, collaborative process for developing interventions in collaboration between the innovators and practice, and really understanding what matters to staff and the system complexity. So I would encourage you to read this, and there are a series of challenges and simple rules as to how we address the evidence gap. And finally, just to summarize the kind of 3 principles of this paper. Firstly, embrace complexity. So you need to understand the systems you're working in, and your intervention will only have the desired impact if it fits with other processes and practices of care. And additional interventions may be required to improve standard practices to make your intervention work. Act scientifically and pragmatically. You will not be able to anticipate all of the challenges and opportunities in advance, although you can predict a lot of them, but you need to be prepared to learn and respond. And finally, you need to engage and empower, which I think has been emphasized throughout today's conference, that your intervention is only likely to succeed if people on the front line put in the effort to make it work. And your change idea is unlikely to be everyone else's priority. So you have to align your change ideas with what matters to them. And just to share, there's some slide references and the QI4U link for the year in an hour case study if you'd like to look at this in more detail. But thank you very much for your attention.